Okay, hi guys, welcome back. This is part 2 in my video series on acid-base balance, acid-base disorders, and ABG interpretation. And in this video, I'll be discussing about acid-base disorders, and most especially I'll be talking about metabolic acidosis. So let us begin. So now let's just talk about the terminology. So firstly, the normal pH. pH, as I mentioned before, is 7.35 to 7.45. That's the range, and the normal value is 7.4. Next, I'll talk about the normal things first, then we'll talk about the abnormal things. So first, normal pH I've covered. Next, normal PaCO2. So that is the partial pressure of CO2 in the arterial blood. So normal PaCO2 ranges from 35 to 45 millimeters of mercury, and in an ABG we take the standard value to be 40. Next is the bicarbonate. Bicarbonate, it ranges from 22 to 26 milliequivalents per liter, and in an ABG you take the standard value to be 24. So now what are these terms, acidemia and alkalemia? So basically what is so anything that has the suffix emia indicates blood. So acidemia and alkalemia suggests that the blood pH is either acidic in acidemia and alkalemia it's alkalotic. So in this condition, so acidemia, alkalemia, we are not talking about any of the other components in an ABG. We're just talking about the pH. So if we see a pH below 7.35, this is called as acidemia. And if we see a pH above 7.45, this is known as an alkalemia. Next, so next point is this PaCO2 is known as the respiratory component in an ABG, and the bicarbonate is known as the metabolic component in an ABG. So any change in the PaCO2 will cause either a respiratory acidosis or an alkalosis, and any change in the bicarbonate will cause either a metabolic alkalosis or a metabolic acidosis. So respiratory acidosis means what? Acidosis means the pH decreases, respiratory means CO2. So how will the pH decrease in a respiratory thing, abnormality? So this occurs when the PaCO2 increases. So PaCO2 increases, leading to increased carbonic acid. That causes a drop in the pH to become more acidic. This is known as respiratory acidosis. And respiratory alkalosis is when the CO2 decreases. That leads to a decrease in the carbonic acid and a decrease in the pH. So what is metabolic acidosis now? Metabolic acidosis is when the bicarbonate level is below 22 and the pH is decreased. Metabolic alkalosis, vice versa, is when the bicarbonate level increases, that is above 26, and the pH increases. Sorry. So now, yeah, I've covered these points: acidemia versus acidosis, alkalemia versus alkalosis, and metabolic versus respiratory. These are basic concepts that I expect every one of you to have understood before going to the next part of the video. So now, what is the Henderson-Hasselbalch equation, and why have I put this here? So this equation is an equation that helps you calculate the pH in the blood using two values, that is the bicarbonate level, and the second one is PaCO2 value. So what is this bicarbonate component? The bicarbonate is the metabolic component. What is the PaCO2? It is the respiratory component. So this equation links pH as a product of the metabolic component and the respiratory component that determine acid-base balance. So how did we get this equation? So I will just explain that. So pH is equal to, so what is the 6.1? 6.1 is pKa of carbonic acid. The actual equation is pH is equal to pKa plus log of base by acid. So that is in case of the bicarbonate buffer system, pH is equal to pKa, which is 6.1 of carbonic acid plus log of the base. The base is bicarbonate, and the denominator should be acid, which is the concentration of H2CO3 carbonic acid. But carbonic acid can also be expressed in a different way. It can be expressed as the solubility of carbon dioxide multiplied by the partial pressure in the arterial system of carbon dioxide. So the solubility of carbon dioxide is 0.03 millimoles per liter per mmHg. This is the solubility of CO2 in the blood. So with this, using this, we have this equation. This equation helps you calculate the pH in the blood. However, it's not practically possible to use this equation when you see an ABG because of the log value. You need a calculator. So what another couple of scientists did was they modified the Henderson-Hasselbalch equation to make it more simple. That is, this modification was known as the Cassirer-Blake modification that was done by two scientists, Cassirer and Blake. So they illustrated that the acid-base balance now depends on the ratio between PCO2 and the bicarbonate. So what can you see between these two? So what can you remember? So basically they've inverted the equation of Henderson-Hasselbalch. Henderson-Hasselbalch was pH is proportional to bicarbonate by 0.03 into CO2. So basically proportional to bicarbonate by CO2. So what has happened here? What is pH? pH is negative log of H plus. So it's inverse of H plus. So H plus, if you invert this equation, you'll get the same thing. H plus is now proportional to PaCO2 by bicarbonate. It's just an inverse. But the fact that makes this equation easier to use is the value. So here he's put 24. So if we put in the normal values in the blood of PaCO2 and bicarbonate, we will get H plus to be 24 into PaCO2 40 divided by bicarbonate 24. It's 24 cancel. So we will get the H plus at in the normal pH of blood to be 40. This is nano equivalents per liter. So this is a simpler way to check the validity of an ABG. So you just plug in these values and check the H plus concentration. And using the H plus, you can get the pH value. So now coming to acid-base disorders. So the first thing, the basic concept in acid-base disorders that I'd like all of you to understand is a change in the PCO2 or a change in the bicarbonate concentration will cause a change in the pH of the extracellular fluid. So this change can either be a primary change in the bicarbonate or it can be a primary change in the PCO2. If the primary change involves the PCO2, is known as a respiratory acid-base disorder, and if the primary change occurs in the bicarbonate, it is known as a metabolic acid-base disorder. Simple thing. There's one more entity of disorders known as mixed acid-base disorders. So in these disorders, basically two different acid-base disorders coexist at the same time. So this is a little more complicated and we'll be covering this a little later. So this slide just tells you about the primary change, the compensation, and the pH. So as I discussed, metabolic acidosis, what is it? It is a decrease in the bicarbonate. So how will you compensate? So remember that equation, a simpler modification of Henderson-Hasselbalch, the Cassirer-Blake. So H plus concentration was proportionate to CO2 by HCO3. You can remember either of the equations and the proportionality. So basically, what happens if the HCO3 decreases, what will happen to H plus? H plus will increase. So H plus increases, what happens to the pH? pH decreases. So how will the body compensate to return the pH back to normal? It should increase the CO2. Sorry, it should decrease the CO2. How will it decrease the CO2? It will decrease the CO2 by hyperventilation. So have you understood? So eventually the pH should revert back to normal. So I'll explain this once more. So if you remember this equation, H plus is proportional to CO2 by bicarbonate concentration. So first remember the primary change. The primary change in metabolic acidosis is that the H plus bicarbonate concentration goes down. So if bicarbonate goes down, the denominator is decreased. If the denominator decreases, the overall value of the reaction will increase. So the H plus concentration will increase. Okay, so if H plus increases, pH decreases. So how will the body compensate? The body somehow has to increase the pH and get it back to the normal value. So how will it increase the pH? So the metabolic component is decreased it. So now the respiratory component should increase the pH by hyperventilation. So hyperventilation will decrease the CO2. When CO2 decreases, that decreases the carbonic acid, and eventually the pH increases. Okay, so it's a little confusing, increases, decreases, but if you remember this equation and understand the basic concept, I'm sure you would have understood. So second thing, respiratory alkalosis. So same way, what happens here? What is the primary change? Primary change is a decrease in the PCO2. So if the PCO2 decreases, what will happen to H plus? H plus will decrease, right? Because it's the numerator is decreased. So PCO2 decreases, H plus decreases. If the H plus decreases, what does that mean for the pH? pH will increase, it will become more alkalotic. So how will the body compensate an increase in alkalinity? It will excrete alkali, right? So it will decrease the bicarbonate concentration in the blood. So next, respiratory acidosis. What happens here? The primary changes increase in the PCO2. If PCO2 increases, what happens to H plus? H plus will also increase. If H plus increases, what will happen to the pH? pH decreases. So this is acidosis. So now how will the body compensate? Body has to compensate by increasing the alkalotic component, that has to increase the bicarbonate. Okay, the last one is metabolic alkalosis. So primary change here is an increase in the bicarbonate. If bicarbonate increases, what will happen to H plus? H plus decreases. H plus decreases means pH increases. So how will the body get the pH down back to normal? It has to increase the carbonic acid. So how will it increase carbonic acid? It will increase the carbonic acid by CO2 retention. So there will eventually be the compensation of raised PCO2. So this is just basic about the primary change, the compensation, and the effect on pH. The mathematical values on how to determine compensation and if this ABG is compensated or not, we will be discussing in further videos. So now coming to the first disorder, metabolic acidosis. So what happens here? Metabolic means what? Bicarbonate is affected. Acidosis means what? Means pH has gone down. So pH has gone down and the bicarbonate concentration is decreased. So the definition is pH below 7.35 and a bicarbonate concentration less than 22 millimoles or milliequivalents per liter. So why does metabolic acidosis happen? What is the mechanism? So if you see, for something to become acidotic, there has to be an increase in the H plus, or there has to be a decrease in the bicarbonate. So that is the first two reasons. Increase in the H plus or decrease in the bicarbonate. The third reason for this is there is a decrease in the excretion of the acid by the kidney. So basically the renal regulatory mechanisms, they fail. So renal mechanism, what was the first mechanism? Excretion of H plus and conservation of bicarbonate. So if this whole process is deranged, then H plus will accumulate in the body and bicarbonate won't be conserved. So basically this will cause a metabolic acidosis. So the first point that I put was increase in endogenous acid production. What are these acids? These can be lactic acidosis, it can be keto acids, it can be acetyl salicylic acid, aspirin, etc. Now the second point is loss of bicarbonate. When does this bicarbonate get lost exactly? So this occurs in diarrhea. Okay, D. And the last one, decreased excretion of net acid by the kidney. When will this happen? This will happen when there's an impairment of the kidney's function. So basically, acute any kidney injury, so either acute kidney injury or chronic kidney disease. In acute kidney injury, you'll have a different acid-base disorder. I'll mention that later. But in chronic kidney disease, this is most common, metabolic acidosis. Now the clinical features. Clinical features here is what you should remember is acidosis depresses and alkalosis stimulates. Basically, acidosis depresses. So there's depression of the CNS and there's depression of the myocardium. So CNS depression includes stupor, lethargy, stupor, coma, confusion, etc. Myocardial depression, decrease in the heart rate, etc. Cardiac output. So whenever this is the primary change, causing the primary clinical features. Next, this is due to compensation. So compensation to increase the CO2 washout, the person has to hyperventilate. So this type of respiration that is seen in metabolic acidosis is known as Kussmaul's respiration. And one more point here that I forgot to write on the slide is whenever the H plus concentration in the blood increases, this H plus is compensated by a K plus shift out of the cell into the extracellular fluid, and the H plus in the extracellular fluid goes into the cell. So basically, if you have a cell and K plus, and you have high H plus here, this H plus will go into the cell and K plus will come out. So you will have also symptoms of hyperkalemia. So whenever we talk about metabolic acidosis, one very important concept that must be discussed is the concept known as anion gap. So what is anion gap? Anion gap is just the difference between the unmeasured anions and the unmeasured cations. So first remember this, the value of anion gap is 8 to 12 milliequivalents per liter. That's the first point I want you to remember. Now the basic concept of anion gap is that you have to remember that the sum of the positive and negative charges in the plasma are always equal in vivo. If they weren't equal, the body would have a net positive or negative charge. So if you have some net charge, if you even touch the ground which is neutral, there will be some passage of current either from the ground to us or from us to the ground. So to prevent this, the body always maintains plasma be of a neutral charge. Okay, so if we express this mathematically, that tells you that cations is equal to anions in the body. Okay, so now how do we measure this? So the measured cations plus unmeasured cations, which is the total cation, should be equal to measured anions plus unmeasured anions. Okay, so simplifying this further, so what is anion gap? It is the difference between unmeasured anions subtracted by unmeasured cations. So if you bring this to this side, you should bring, sorry, if you bring this to this side, you have to bring this to this side. So is equal to measured cations minus measured anions. We just clear this. So what is anion gap? It is measured cations minus measured anions. So what are the cations we measure? We we can measure sodium, we can measure potassium, we can measure calcium, we can measure magnesium. But in the anion gap calculations, we only take one cation. That is the value of sodium. Next, the anions. What are the anions? You can measure chloride, you can measure bicarbonate, you can even measure lactate, acetate, acetoacetate, etc. But the two components we take are chloride and bicarbonate for calculation. So the value is the anion gap is measured cations, which is sodium minus measured anions, the sum of chloride by bicarbonate. So taking normal sodium value is 140, normal chloride value is 104, and bicarbonate value of 24. You have 140 minus 128, which gives you 12. So the normal value, as I said, is 8 to 12. All right. So one more thing to remember is when we're calculating an anion gap is we have to correct it in case of any hypoalbuminemia, because the unmeasured anion is predominantly albumin, anionic albumin. It also consists of phosphate, sulfate, etc. One of the predominant unmeasured anions is anionic albumin. So if this is less, so for every 1 gram per deciliter decrease in albumin below 4.5 grams per deciliter, which is the normal value, the anion gap increases by 2.5 milliequivalents per liter. I'll repeat that again. So for every 1 gram per deciliter decrease in serum albumin below 4.5, the anion gap increases by 2.5 milliequivalents per liter. This is the correction in case of hypoalbuminemia. Next, we'll be discussing causes of. So metabolic acidosis can be divided into high anion gap metabolic acidosis and normal anion gap metabolic acidosis based on the value of the anion gap. First, high anion gap metabolic acidosis. What the causes? So there's a mnemonic. This is called as gold mark. There are also other mnemonics. There is cup smile, etc. There are other mnemonics are there. I personally find this one easy to use. So what is gold mark? So G stands for glycols. Glycols are ethylene glycol, propylene glycol. O, 5-oxoproline. L stands for L-lactate. So basically in lactate, you have D-lactate and L-lactate. So L-lactate is the lactate that is produced in type A and type B lactic acidosis. So type A lactic acidosis occurs when there's decreased perfusion of the cells, that is hypoxia. So in cases of severe anemia, shock, congestive cardiac failure, etc., there'll be increased L-lactate, and this is called as type A lactic acidosis. Okay. Type B lactic acidosis, in type B there's also increased L-lactate, but the cause is different. So here it is due to predominantly a change in the aerobic metabolism of the cells that occurs in malignancies and drugs. This is type B lactic acidosis. Next, D stands for D-lactate. What is D-lactate? D-lactate is synthesized by gut bacteria. So when will this increase? This increase when in certain cases of short bowel syndrome or jejunal-ileal bypass, and this can cause metabolic acidosis, high anion gap metabolic acidosis. Next one, M stands for methanol, methanol poisoning. A is aspirin poisoning, acetyl salicylic acid. Next, A is acute renal injury, acute kidney injury. R stands for rhabdomyolysis. Finally, K stands for ketoacidosis. This can be either DK or alcoholic ketoacidosis. So this gold mark is a mnemonic that helps you remember the causes of high anion gap metabolic acidosis. So next, the second type is normal anion gap metabolic acidosis. So when will this happen? So if you remember the anion gap formula, sodium minus of sum of chloride plus bicarbonate. So metabolic acidosis per se means a decrease in the bicarbonate. So when will bicarbonate decrease but the anion gap will remain normal? Then, so this will only occur if there's an increase in the chloride. So to compensate for the decrease in the bicarbonate, there's an increase in the chloride ions to retain the electron neutrality. So this is known as normal anion gap metabolic acidosis or hyperchloremic metabolic acidosis. So what are the causes of normal anion gap metabolic acidosis? The first cause is GI loss of bicarbonate, that is diarrhea. Second cause, impaired renal acidification leading to an increased urinary bicarbonate loss in renal tubular acidosis. And the third one is early stages of AKI when the acid excretion is impaired. These are the causes of normal anion gap acidosis. Now I'll explain the concept. So what should happen when there is a hyperchloremic metabolic acidosis? So if anything goes up, the body will compensate by decreasing it. So the chloride levels now go up. So how will the body compensate? The body should excrete this chloride. So how will this chloride be excreted? So if you can remember in my previous class, chloride can be excreted in the form of NH4Cl. This is actually one way the renal regulation works. It excretes ammonia as ammonium chloride. So ideally, when this chloride increases in the blood, it will be excreted as ammonium chloride by the kidneys. But say there's a problem in the kidneys. That is, there's either impaired renal acidification or there are early stages of AKI when acid excretion is impaired. Is it possible for the kidneys, which are not functioning properly, to excrete the chloride as ammonium chloride? No, it's not possible. So the chloride level will increase in the blood, but in the urine, the chloride levels will still be low. Okay, so this is one concept. Whereas in an extrarenal cause of normal anion gap metabolic acidosis, the increase in chloride in the blood will be compensated by an increase in urinary chloride. So the body, the renal, because the kidneys are functioning normally, it will excrete this increased chloride in the form of NH4Cl, and eventually the chloride level will decrease in the blood. So how can we differentiate these two different causes of normal anion gap metabolic acidosis? So we see this by checking the urinary ammonia or the urine anion gap or the urine osmolar gap. So these causes are the first cause is the extrarenal cause, that is bicarbonate loss in the GIT by diarrhea. The second one are the renal causes of normal anion gap metabolic acidosis. What were the two renal causes? The first one was impaired acidification in RTA. Second one was early stages of acute kidney injury. So we can differentiate between renal and extrarenal causes of normal anion gap metabolic acidosis. So now how do we use urine ammonia? Same way as if the kidney is not functioning normally, it won't be able to excrete the ammonia in the urine. So obviously urine ammonia will be less in renal causes of normal anion gap metabolic acidosis. Next one, urine anion gap. But this urine ammonia, it's rarely measured in the labs. So we have to find out a different way of finding out the difference between a renal cause and an extrarenal cause of NAGMA. So this, how do we find this? We use the urine anion gap. Urine anion gap, what is it? It is urine sodium plus potassium minus chloride. urinary chloride. So in a normal situation, will this be positive or negative? So in a normal situation, this will be negative because urinary chloride is high, because chloride combines with ammonia to form ammonium chloride. But if there is a renal problem, the chloride cannot be excreted. So obviously the chloride level will decrease and the urine anion gap will increase. So basically a positive value of a urine anion gap suggests that it is a renal cause of normal anion metabolic acidosis, and a negative cause suggests that it's a GI cause of normal anion gap metabolic acidosis. Okay? So one more thing is the urine osmolar gap. I don't want to go too detail into this, but basically you should just remember that what is osmolar gap? It is the difference between measured osmolality and calculated osmolality. So I will actually explain this later in another video, but basically what you should remember is osmolality in the urine measure. The calculated osmolality is calculated by 2 into sodium concentration plus 2 into potassium concentration plus urine urea by 2.8 plus urine glucose by 18. So in diabetics, only in diabetics you'll consider the urine glucose by 18, because otherwise in normal cases you won't be having glucose in the urine. So using this formula, you can calculate the osmolality in the urine, and basically finally, if you get a value of an osmolar gap to be less than 40 millimoles per liter, that suggests that you have impaired excretion of urinary ammonia, which suggests that it's a renal cause. So don't go too much into depth about the urine osmolar gap, because the urine anion gap is much simpler and easier to calculate. So now one more concept I'll be explaining is the delta ratio. So what is this delta ratio? Delta is change. So a delta ratio is the ratio between the change in the anion gap divided by the change in the bicarbonate concentration. So I express that mathematically. So the anion gap is anion gap minus 12 divided by 24 minus bicarbonate concentration. So when do you calculate this delta ratio? Do you do it for everyone? No, you only calculate this when there's an elevated anion gap. And why do we calculate this delta ratio? This is to rule out the coexistence of two different acid-base disorders coexisting. So what is this condition called when two acid-base disorders coexist? It is called a mixed acid-base disorder. So you calculate the delta ratio to rule out the presence of a mixed acid-base disorder when there is an elevated anion gap. What is the concept behind this? Concept is that what you're expecting is, in a simple acid-base disorder, that for every 1 unit increase in the anion gap above the normal, the bicarbonate value should also decrease by 1 unit. What does this mean? This means that every unit, so say the anion gap increases by 1, you're expecting anion gap to increase by 1. That means you should also expect the bicarbonate to decrease by 1. That's all. It's pretty straightforward. So I just want to give a question to test your understanding of anion gap and delta ratio. So say, take this ABG. Forget the values of pH, PCO2 and bicarbonate. Question is to calculate anion gap and delta ratio. So how do we calculate anion gap? Anion gap is sodium minus of chloride plus bicarbonate. So what is the value here? 139 minus 88 plus 13. So 139 minus 101, 38. So that is the anion gap. Erase these. So anion gap is 38. So what does that tell you? That tells you there's an elevated anion gap. Second part of the problem, the delta ratio. How do we calculate this? Delta ratio is the change in anion gap divided by change in bicarbonate. So what is the change in the anion gap? It is 38, the new anion gap minus the value of the expected 12 divided by 24, this is normal bicarbonate, minus 13, the current value. So you have 26 by 11. What is 26 by 11? Roughly 2.3. The delta ratio is 2.3. So what is the answer here? The answer is option C. So now how do we interpret this delta ratio? So as we saw in the previous problem, the delta ratio was 2.3. So what is the interpretation of that? I'll come to that. So now first learn the normal value of delta ratio when you expect primary disorder. So a primary disorder, that is high anion gap metabolic acidosis, delta ratio should ideally be within 1 to 2 to suggest that the only disorder is a pure high anion gap metabolic acidosis, since you only calculate the delta ratio when there's a high anion gap. So 1 to 2 suggests pure high anion gap metabolic acidosis. Now what if delta ratio is below 1? What does that indicate? So let us just write the delta ratio. Delta ratio is delta anion gap by delta bicarbonate. So if the delta ratio is less than 1, suggests that the denominator is high. The denominator is high, it means the change in bicarbonate should be high. The change in bicarbonate is high, it means that bicarbonate is being lost elsewhere. That you're basically getting an increased loss of bicarbonate somehow. So how will that happen? This will happen only if there's a high anion gap metabolic acidosis with a normal anion gap metabolic acidosis also. So together these two processes will deplete the bicarbonate, making it such that there's a large change in the value of the delta bicarbonate. Okay. Now what if delta bicarbonate is the delta ratio is more than 2? Delta ratio more than 2 suggests the denominator is it's small, so the change in bicarbonate is less from the normal. So when will that happen? So it will happen if there's an alkalotic process increasing the bicarbonate. So the answer is when there's a high anion gap metabolic acidosis plus a corresponding metabolic alkalosis, not compensatory, I'm sorry, high anion gap metabolic acidosis with the coexisting metabolic alkalosis, that will increase the delta ratio above 2. So this way you can find out in conditions where there's an increased anion gap, you can find out whether there's a mixed acid base disorder or a pure acid or single or pure acid base disorder. Thank you very much.